Hello everyone and welcome to this HELIConference webinar on the social differences in COVID-19 vaccination in Belgium. My name is Brecht de Vleeschouwer and I have the honor to be the host and moderator for today's webinar. I'm also the head of the service Health Information at Cienzano, and this webinar is presented to you within the context of the HELICON project, which is kindly supported by BELSPO. Before we dive into the program, I would like to give you some background on the underlying project. So HELICON is a BELSPO project that will run until the year 2025, and it's a collaboration between Cienzano, the VUB, UGent, UC Louvain, and KU Leuven. The overall ambition of the HELICON project is to understand and unravel, on the one hand, the social inequalities in the COVID-19 crisis, but also the long-term and indirect health effects of the crisis. So we are active in three main pillars: inequalities, long COVID, and the indirect effects, for instance, related to delayed healthcare use. In the project, we will generate new evidence ourselves, but we are also very encouraged to collect and disseminate all evidence that is being generated in Belgium across these three pillars. So it's in this context that we are then organizing this webinar, where we are bringing together experts from across Belgium who are sharing with you their insights and expertise. So the focus of today's webinar will be on the social inequalities in COVID-19 vaccination. And I don't think that I have to convince you that Belgium was a very good example of achieving a high vaccination coverage. So we need to, of course, start with a very positive point. But at the same time, we see and have seen that not everyone, not every part of the population reached the same vaccination coverage. So with this webinar, we want to first start by understanding what these differences are, these socioeconomic and sociodemographic differences are. But then we also want to zoom in on possible solutions, possible explanations for these differences and strategies to prevent them. And to cover these topics, we have invited key experts who have been very active in COVID-19 and vaccination in particular in the past few years. So we will start with a presentation by Professor Christel Faes from the University of HELICON, who will identify the geographical patterns in COVID vaccination coverage with a focus on Flanders. Our next speaker will be Lisa Cavio from Cienzano and UC Louvain, who will zoom in on individual level differences, focusing on sociodemographic and socioeconomic characteristics. So these two first presentations will set the scene and will identify the disparities that exist. The third presentation, provided by Professor Sophie Tunus from UC Louvain and Professor Céline Mailleux from the Université Libre de Bruxelles, will zoom in on the possible solutions. So they have set up qualitative research studies trying to identify the challenges and also the possibilities to overcome these inequalities. We will conclude with closing remarks from Dr. Wouter Arrazola de Ognate from the Belgian Lung and Tuberculosis Association and also the Flemish counterpart. And he will provide his general remarks on the webinar and will conclude with some perspectives from his personal experience throughout the crisis. So first things first, some administrative issues. Throughout the webinar, we will make sure that your microphones remain switched off so that there's no background noise. You are, of course, very welcome to keep your videos open so that we know who we are talking to. Each presentation will last around 10 minutes and will be followed by a period of around 5 minutes for Q&A. So if you would have any questions during the presentations, don't hesitate to put your questions in the chat box, and we will then moderate these questions. The slides and also the recording of the webinar will become available via our website, brainhelicon.be, shortly after the closure of the webinar. So with that, I'm very happy to give the floor to our first speaker, Professor Christel Faes. And she is a professor in statistics at HELICON University within the Data Science Institute. Her research interests include the statistical analysis of geographical data and Bayesian estimation methods. She is applying these methods to many different topics, but also to infectious diseases and to COVID-19 in particular. So we believe that she's a very good speaker to get us started here. So Christel, the floor is yours, and feel free to start sharing your presentation. Thank you.
Okay, thanks a lot, Brecht, for the kind introduction and also for the invitation. I'm trying to share here my screen, but since you were still sharing, it was not possible, but I see you have stopped sharing now. Okay, there we are. So indeed, as Brecht mentioned, I would like to talk about some geographical variation of COVID-19 vaccination in Flanders, where an analysis that we conducted during the pandemic times, and which is an analysis at an aggregate level. So it's really a geographical analysis. I don't have to say that, of course, COVID-19 vaccines was used in the fight against the global pandemic, and that since 2021, in many countries all around the world, national vaccination plans rolled out, luckily. But of course, as you see here on the map also, there is quite a lot of variation in vaccination availability in many countries. Vaccination availability, I'm saying here, but it's of course also vaccination willingness. Also, well, what is very important is of course, if vaccination or to get vaccination work, to stop circulation of the virus, we need a good vaccination coverage. Now, if we zoom in into Belgium and in Flanders, we also see that there are quite a lot of differences. And of course, the vaccine was available for everyone in Flanders. So if we zoom in into Flanders, we really look at differences in terms of vaccine willingness. If you dig in literature, you indeed see that vaccine hesitancy is very variable in various population subgroups. Also in the US and the UK, there has been quite a lot of research about this, comparing rural versus urban, but also groups with different social vulnerability, showing that less social or more social vulnerable individuals typically have lower vaccination rates, also minority groups, etc. In Flanders, there is also the Great Corona Study, which was conducted during the pandemic times, which also looked at vaccination hesitancy. And also from that study, it showed that there was lower vaccination willingness in individuals with a lower educational background, larger household size, lower income, and lower mental well-being. Now, in this study, what we wanted to look at is, first, we wanted to know, are there regions in Flanders with a lower vaccination coverage? And if so, whether it was linked to ethnic diversity, age, or composition of origin. The question actually came from the primary healthcare zone Maasland region, which is located here, really in the east of Flanders. And because that region was really interested in understanding the vaccination coverage, because they noticed that in this healthcare region, vaccination willingness was lower as compared to other regions in Flanders. So to study this, we worked with data from vaccination in Flanders from the Flemish Control Tower from the agency Health and Care. So where the study population is all individuals above 12 years, because those were the individuals that at the time of the study, which was in November 2021, did have had the opportunity to get fully vaccinated. And in this data set, we have data per statistical sector. So it's not at the individual level. We only have information at the statistical sector and per age groups. Yeah. So, and with this information, we tried to better understand vaccination differences. I just want to note that there were some also incomplete registrations of the locations of the residential locations of individuals, and multiple imputation was conducted for that. So in summary, what we saw here, this is a presentation of the vaccination rates in Flanders across different age groups. And every dot here in this figure is actually the vaccination rate, the reported vaccination rate in a statistical sector. So every dot is a statistical sector with the size of the dot corresponding to the size of these statistical sectors. If we look at overall numbers, we see luckily that we had a very positive vaccination campaign in Flanders with high vaccination rates overall. The black numbers here are the overall percentages of vaccination coverage in Flanders for the different age groups, and we see high numbers here. Of course, a little bit lower numbers in the younger age groups. And in comparison, in blue, the plots or the figures next to that are the values in the health sector Maasland. And you can see that these numbers are typically a little bit lower as compared to the average in Flanders, especially in these two youngest age groups. Now, what you also see in this graph is that if you would look, for example, or take as threshold 80% of vaccination rate, we see that all these statistical sectors, all these dots are statistical sectors where the vaccination rate is lower than 80%. Yeah? So in that sense, there seems to be also locally some improvements possible in vaccination rate. Now, of course, possibly this is just due to age differences or other factors. And that's why the first step we wanted to take is to look at, are there geographical differences in vaccination rate after correction for the age distribution? So we did that by modeling the number of vaccinated individuals and correcting for the expected number of vaccinated individuals based on the age-specific vaccination rate in Flanders. Yeah? And after modeling this, we can look at these vaccination rates as compared to vaccination rate in Flanders. So this, the values that we present here, kind of age-standardized vaccination ratio, when the value is below 1, so in the graph in orange or in red, it means that the vaccination rate in those areas is lower as compared to the average in Flanders. And you see immediately on the map that, for example, the region around Brussels stands out, the region in Antwerp, some regions in the close to the boundary with the Netherlands, and also here our region of interest, Maasland region, which has lower values. So in the next step, we then wanted to link this to what is the population background in those areas. So what is the ethnic origin and what is the socioeconomic status? Yeah? And for this, we looked actually at two different possibilities. So first, we looked at what is just the proportion of individuals that are non-Belgian and where did they come from. So this is the percentage of Flemish population with an origin from Maghreb, Netherlands, Asia, etc. Yeah? So can we use these percentages to explain the coverage? Another way is to summarize all these proportions in a kind of diversity index. So diversity with respect to origin, with higher values, here colored in green, corresponding to more diverse populations. So with typically areas consisting of inhabitants with different origins, and red corresponding to the lower diversity, so areas with less diversity. And also here some trends are clearly visible. Also socioeconomic status was looked at by defining it as a proportion of individuals with increased health insurance. So we looked at some models linking the number of vaccinated individuals with the diversity and the composition. So the first thing, of course, we noted was differences in terms of age structure, with especially the age 65 to 84 having the highest odds ratio to get vaccinated. Also, we see regions with lower socioeconomic status to have lower vaccination rates. But if you look at also the diversity index, we see that in areas where there is a higher diversity, we see clearly that there is a lower vaccination willingness, lower values in all age categories. But also, on the other hand, areas with a very low diversity, also there we see lower vaccination, especially in the elderly age groups, not so in the younger age groups. If we look at the effect of the composition, let's say, on the odds to be vaccinated, we see that actually all the odds ratios are here below 1, indicating that whenever you move away from a population which is different from the average population composition in Flanders, we see a decrease in vaccination rate, with some of the countries sticking out, like France and the East European countries. So in conclusion, I want to say, okay, vaccination campaign in Flanders has been a success, though there is large heterogeneity. And these differences are certainly due to age composition, but also composition with respect to ethnicity and socioeconomic status. And for the ethnicity explains for the Maasland region, the health care region, a reduction of 35%. Yeah. So with this, I would like to wrap up. Thank all the co-authors for this work, and for any questions, of course, if there's still a little bit time here, but otherwise you can always also contact me.
Perfect. Thanks a lot, Christel. And indeed, we have 2 minutes for maybe one question from the audience. David, I see you have your hand up, so you're the first one to take the floor. David, go ahead.
Thank you. Thanks for presenting these interesting results. I was wondering if there are any plans to relate vaccination status to income directly, not only by the heightened reimbursements that you use now, because mean fiscal income is available at the statistical sector level too. So I was wondering if there are any plans to use that indicator also. Thank you.
Sorry, I did not understand the question. To link it to income?
So you can mean fiscal or median fiscal income is available at the statistic.
Yes, indeed. Yeah. Indeed, we did not do that. We, like I said, we used the percentage of individuals with a reduced. Now I cannot find the words.
Reimbursement status.
Yes, the
reimbursement
status indeed, like this. But indeed, I think also the use of income would be really interesting. And well, we did not have any plans to further proceed with this. But if there's interest, I think it would be really useful to indeed try. Yeah.
Okay. Thank you.
Okay, thanks. And this then also links up to the next presentation. that will be presented by Lisa Cavio. And there she will present results of a study where we were able to link this information at the individual level, including income, but also the other variables that we have seen before. So I see that Lisa has her presentation up. And Lisa is currently pursuing her PhD in public health at the Université Catholique de Louvain in collaboration with Cienzano. Her PhD dissertation focuses on the social inequalities encountered during the COVID-19 pandemic, and it builds on the LinkVac and the HELICON projects at Cienzano. So Lisa, feel free to take the floor. Thank you.
Correct. Hello everyone. So I'm very pleased to be here today to present you our research on sociodemographic and socioeconomic disparities in COVID-19 vaccine uptake in Belgium. So it's a collaboration between the HELICON project and the LinkVac project. So in the scientific literature, it has been widely demonstrated that there is a higher rate of SARS-CoV-2 infection and COVID-19 severe outcome among certain sociodemographic groups, such as men, elderly, or migrant, and also among socioeconomic disadvantaged groups, for example, among people with low income or low education. But it has also been demonstrated that the vaccine against COVID-19 reduces effectively the transmission of the virus and the development of COVID-19 severe outcome. We therefore wanted to assess whether the COVID-19 vaccination coverage was equitable in Belgium, or if a social gradient was present. Our research question was therefore the following. So are there any sociodemographic or socioeconomic disparities in COVID-19 vaccine uptake in Belgium and in all of its regions? To carry out this study, we used individual data available from several national registers. As the outcome, we used the first COVID-19 vaccine doses as of 31 August 2021, because it marks the reaching of the vaccination plateau for the first COVID-19 vaccine doses. As a covariate, we selected several sociodemographic and socioeconomic variables. As sociodemographic variables, we selected age, gender, region, household type, and migration background. And as socioeconomic variables, we selected income, education level, employment status, and healthcare diploma. On this graph, you can see the vaccination coverage over time per age group and region in Belgium, as each region were responsible for the vaccination rollout. So as of 31 August 2021, represented by the black vertical line, you can see that almost all age groups reached the vaccination plateau for the vaccination, the first COVID-19 vaccine doses in all the regions. And it's also important to state that the first COVID-19 vaccine doses is a good predictor for the primary vaccination schedule, because among those who received the first doses, almost 100% completed their primary vaccination schedule. So to carry out this study, we use data from the LinkVac project, who gathers data on all individuals tested and or vaccinated for COVID-19 in Belgium. And so as of 31 August 2021, approximately 10.5 million individuals were tested and or vaccinated for COVID-19 in Belgium, and it represents 90.92% of the total Belgian population. So we have a very high coverage of the Belgian population thanks to this data. So among this sample, we selected all Belgian adults tested at least once for COVID-19 in Belgium by August 31, 2021. And then we made the link with the sociodemographic and socioeconomic data. And so we have a final sample of approximately 5.3 million people, of which 10% were not vaccinated with the first COVID-19 vaccine doses. Concerning the statistical method, we use logistic regression models to model the probability of being not vaccinated with the first COVID-19 vaccine doses. we performed 3 logistic regression models. The first model was applied on the whole study sample, so people age over 18, and included as covariate sex, region, migration background, household type, and income. Then we perform a second model, but applied only on individual age over 25, where we included, in addition to all the covariate included in the model 1, the education level and the possession of a degree in health. Then we conducted a third logistic regression model applied on all individual age between 25 and 65, and so with all the covariate included in the model 1, but we added the employment status, and we removed income because the income and employment status are two very correlated variables. So I'm going to present you the result of our study. So on this graph, you can see the adjusted ratio and 95% confidence interval for the association between, firstly, the sociodemographic determinants and the odds of not having received a first COVID-19 vaccine doses in Belgium as of 31 August 2021. So concerning the age group, we can see a gradient. So the younger you are, the less vaccinated you are. For the sex, we identify a slight lower COVID-19 vaccine coverage among men compared to women. For the region, we identify a lower COVID-19 vaccine uptake in Brussels and in Wallonia compared to the Flemish region. Concerning the migration background, we identify a lower COVID-19 vaccine uptake among second-generation migrants, first-generation European migrants, and first-generation non-European migrants compared to Belgian native. And finally, the effect is lighter, but we still identify some disparities in the household type. So we identify a lower COVID-19 vaccine uptake among single parent and one person household compared to couple with kids. So I'm going to present you the same result, but for the association between socioeconomic determinants and the odds of not having received a first COVID-19 vaccine doses. So concerning the income, we identify a lower COVID-19 vaccine uptake among people with moderate income, low income, and missing income compared to people with high income. For the model 2, so applied only on individual age over 25, we identify a lower COVID-19 vaccine uptake among people with moderate education, low education, and missing education compared to people with high education. And concerning the healthcare degree, we identify a lower COVID-19 vaccine uptake among those without a healthcare degree compared to those with a degree in health. And finally, in the model 3, so applied on individual age between 25 and 65, we identify that people without unemployment and people with a missing employment status were more likely to be not vaccinated compared to people employed. So in conclusion, we identify important social disparities in the COVID-19 vaccine uptake in Belgium, so among young people, migrants, single parents, one-person household, and socioeconomic disadvantaged groups, so people with low income, low education level, and unemployed. And we also identify identical patterns within each Belgian region. So this research provides new insight into social patterns in vaccine uptake, and these insights are useful to identify potentially vulnerable population in the next wave of the epidemic or other future epidemic. Thank you.
Okay, excellent. Thanks a lot, Lisa. And as before, we have a few minutes for questions and answers. So if you would have a question for Lisa, you can type it directly in the chat, or you can raise your hand and take the floor. And as we wait for some questions, maybe a question from my side. So here we have found that men had lower vaccination status than women, right? But in other studies in other countries, we actually found, or they found an opposite relationship. Some have linked that to certain certain theories related to vaccination reducing fertility or having an impact on women's health. Do you have any insights on what could explain this difference between the current study where women do seem to have a higher vaccination coverage than what we have observed in other countries?
Mm-hmm. Yes, so indeed it's also observed in other countries, and women have also a higher vaccine hesitancy compared to men in studying vaccine hesitancy. The effect is very slight, but I don't know exactly why in Belgium men are more likely to be not vaccinated compared to women. It's a very good question.
Okay.
I don't know.
No, so I think it's useful that these studies can identify new hypotheses and new challenges to further explore. I see that Steven also wants to ask a question or make a comment.
Yeah, I also have a question, Lisa. Do you have any explanation why you see a lower vaccine uptake in single parents or one-person households? That seems a bit odd to me. What would be the hypothesis there?
So, based on the scientific literature, the hypotheses are for single parents. They have to take care of their children alone, and so maybe they do not want to be vaccinated because of the side effect of the vaccine. So maybe they won't be able to take care of their kids after the vaccination. And for one person household, an hypothesis was that they can go to the vaccination center by themselves, maybe. So it was one of the hypotheses to explain this lower COVID-19 vaccination coverage in the scientific literature.
Yeah, thank you.
Okay, great, thanks. So I suggest we can then move on to our third presentation. So thanks a lot, Lisa and Christel, and your presentations have set the scene, have identified the challenges that we are faced with. But of course, these statistical analyses don't provide answers to what we can do to overcome these challenges. So that's why we've also invited Professor Tunus and Mailleux from UC Louvain and ULB, who will present us some insights that they obtained through qualitative research studies. So first of all, I believe that Professor Tunus will do the presentation, but that this work was prepared together. So Professor Tunus is Professor of Management of Healthcare Services at the Université Catholique de Louvain, and she's an expert in qualitative research on transformations within healthcare systems. Her colleague Céline Mailleux is a sociologist and professor at the Université Libre de Bruxelles, and her research interests include, amongst others, public action and health professionals, the construction of social inequalities in health, and the application of qualitative methods to investigate these research questions. So I see that you have your presentation up for us, so thanks a lot, and feel free to take the floor. Thank you.
Okay. Good afternoon, everybody, and thank you very much for your invitation. The title of this presentation is Vaccessible: From Accessibility to Acceptability. And in this presentation, I will very quickly introduce the results of a qualitative evaluation research on Brussels local actions of vaccination. This research had been carried out together with Alexis Créten, who was a researcher at UC Louvain, and with Céline Mailleux from ULB. Can go to the next slide. Can you skip the presentation, please? Okay.
I did, but I think it takes a few seconds.
Don't worry, no problem. So just for the context, as you know very well, at the spring 2021, public health authorities were facing a decrease in the daily number of new vaccination. And Brussels authorities decided to complement large vaccination centers with new local actions of vaccination. And the name of this new policy strategy was Leave No One Behind. The specificity of our research is that we looked at these local actions of vaccination and at the big vaccination centers as policy instruments. What does it mean? It means that we see these centers in action as assemblage of people with particular knowledge and using specific tools. We also assume that these instruments convey a very particular view of a collective problem, in this case, the vaccination and vaccination rate, and that through their very conception, implementation, and evaluation, these instruments contribute to define and to redefine the collective problem. We can go to the next slide. Concerning the methods, we combine different qualitative methods, that is observation, interviews, and focus group, in a way to involve different key stakeholders in the research, namely the Brussels citizen, the local action workers, and policymakers. In total, we met 104 persons over 6 months. Okay. I go directly to the results, and I'm going to present you 3 categories, or more precisely, 3 ideal types. I have to specify here that we also reflect on the particular role of professionals, health professionals, in the vaccination strategy, but we decided to focus on the policy instrument for this presentation. So you can find another typology concerning professional roles in the report. But let's focus on the policy instrument. To describe them and to understand their respective objectives, we decided to build 3 ideal types, 3 conceptual categories based on our data. So ideal types are broad conceptual categories, and each category corresponds to several different empirical policy instruments. Each category summarizes their main characteristics. So it means that they're non-exhaustive, and their main characteristics are summarized in terms of the involved actors, knowledge and tools, publics, temporality, scope, governance model, and core policy principles. So let's go for the presentation of the 3 ideal types. So the first one, the first policy device or policy instrument, is called the invitation. With this policy device, each person with a national identity number is connected to vaccination through simple electronic or post-invitation. So it implies an independent, informed, and connected citizen who is able to move to the vaccination center and who is willing to get vaccinated. The invitation incorporates a very centralized governance according to which the population, which is sorted by age or risk group, move towards vaccination centers. Here we see the logic of a bureaucratic state, which is represented by administrative procedures, and also the logic of impersonal medicine, which is equally inscribed in the very organization of the centers. Indeed, despite the presence of green plants and sometimes of Belgian speculoos, These big centers constitute impersonal framework where the relationship between citizens and the administrative and healthcare staffs are limited to quick contacts, which are often mediated by administrative procedures or technological devices such as QR codes. The invitation that conveys a feeling of effectiveness, rationality, and universality. And in terms of objective, it makes the vaccines accessible to a very large number of people. Then regarding the proposal, we emphasize that it is immediately available in the public space. It takes different forms such as tents or buses, and it is aimed at people who are hesitating to get vaccinated and for whom vaccination is not a priority. The proposal incorporates a decentralized, territorial, and opportunistic governance. It's released on mobile and temporary devices, which are placed in the way of people passing by. They literally get in their way in order to get into their agenda. Thanks to their location in the public space, they are associated to local power and they represent a more human medicine. Indeed, in this very local framework, administrative and medical staffs take the necessary time to speak with the citizens and to respond to their questions. The fact that administrative formalities are kept to a minimum in these local actions also makes more room for human contacts. Finally, in terms of objective, the proposal makes vaccination accessible to a reduced number of people compared with the invitation, but it makes it acceptable to many hesitant people. The third type of policy instrument is called the relationship. According to our conceptualization, it is aimed at vulnerable population and our dependent people who are hesitant or opposed to vaccination. The relationship is embedded in existing health care and social structures. This instrument incorporates a decentralized and relational governance. It is embedded in local structures and connected to long-term trust relationships between the citizens and social or healthcare workers. The relationship sometimes pre-exists, and when it doesn't, health professionals and social workers deliberately attempt to reconnect people to the healthcare and social systems. In this case, time is not only given to the human relationship, but this relationship is the very object of the work. It offers a very personal framework for vaccination, which conveys a feeling of trust. In terms of objective, this device increases the acceptability of the vaccine, but for a limited number of people. And in addition, given its very long-term orientation, it might contribute to social cohesion. With the next slide, it's a table summarizing the results. So you see a comparison of the three type of instruments, invitation, proposal, and relationships in terms of public governance, leading figures, and so on. But I skip to the conclusion immediately because I would like to emphasize that with the development and the implementation of different kinds of local action, which we summarized with the three ideal types of the invitation, the proposal, and the relationships, we saw that policy objectives finally expanded from accessibility to trust, from vaccination quantity to the quality of the vaccination. On the other hand, policy solutions, so the instrument, expanded from universalist logic to a more person-specific logic. This instrument finally appeared as very complementary at that stage of the vaccination policy. And the proposal and the relationship as policy instruments seem to make sense in a mid to long-term strategy, going beyond the specific objective of vaccination, because it helps reconnect vulnerable population to with the healthcare system. Thank you for your attention, and you can access the research report with this link. Thanks.
Okay, perfect. Thanks a lot, Sophie and Céline, for this very interesting presentation. It's indeed very nice to see that it is possible to distill different policy frameworks, different models within which the vaccination campaign could be set up. So I see here a question from Pierre Becker in the chat, asking about the COVID safe ticket policy. Would you see this as a fourth way?
Sorry, I cannot hear.
Do you hear me, Sophie?
No, it helps to distinguish between different framework, but then I...
Yeah. Do the others also have difficulty hearing me? No. Céline, maybe you can try to have a look at the question in the chat. So the question is about the COVID safe ticket policy, which was introduced at some point and which had, at least as an indirect effect, that vaccination coverage could be increased. So would you see this as a fourth model, or is it something totally different, or does it fit within any of the existing defined?
Yes, it could, but actually we started the research. Yes, it was a methodological decision to exclude the COVID safe ticket simply because it wasn't implemented when we started the research. Our categories are based with empirical data collected through interviews with the public, so it's very hard to state that it could be a fourth category, but maybe I don't know. It could be very interesting to do research on that topic.
Yeah. Okay. Thanks. So let's see, because we still have time for some more questions from the audience. In the meantime, maybe a question from my side. So based on the insights that you have obtained now, suppose that it would be possible to redo the whole vaccination campaign. How would you have set up an ideal campaign?
It's a very, very good question. First, yeah, we formulated some policy recommendation at the end of the report, but maybe that these three complementary devices should have been implemented at the beginning of the campaign. And another important recommendation concerned the communication of a policymaker, but also the communication of the media, because they were very stigmatizing for a specific age group or specific type of population, and then it would have been very interesting to consider publics based on their needs and to think about the policy instruments based on public needs rather than social characteristics or cultural characteristics, which are very stigmatizing. And Céline can continue, I guess.
Yes, I would like to add also in terms of recommendation that what we saw also in the attitudes of professionals was that there were different types of attitudes and willingness to be part of this sensibilization to vaccination, and the policymakers tended to take for granted the participation of these professionals and social workers. So as Sophie said, we were able to see that there were at least 5 types of attitudes from this professional, from the more active ones who think that it was their mission to do this sensibilization, even sometimes admonishing the hesitant and the anti-vaccine people. And at the other hand, you find the more reluctant professional and social workers who think that the sensibilization tended to stigmatize certain categories of population, who thinks that it was not their place to do active sensibilization, because it was too focused on the vaccine and not focused on the global health problems, social problems of this population. And this kind of professional was afraid by the conflict with this population and the risk for the link of trust with the patients. And I think this could be also a good point for next policy, to take in account these various attitudes from the professional and social workers, and to take them with the policy.
Mm-hmm. Yeah, no, indeed, also a very important dimension that we haven't covered in the webinar, but the healthcare professionals, of course, play a very crucial role in the whole process. Mohammed, I see that you also wanted to add to that. Thank you.
Yes, thank you, and good afternoon, everybody. Well, I just noticed here about the fact of the statistics for the second speaker, I believe it was. So there is a lot of data, as we don't have, or in the time of the vaccination, there was no sharing data between countries, at least. So a lot of people from the, let's say, Belgians from foreigner origin, they have taken the vaccination from their first countries. So this is kind of a very important note, I believe, that can make really a big difference in the data. So I don't know how accurate is you think, or this data is you are sharing right now, at least, is. And also another point is who have been taking the vaccination, or haven't been taking the vaccination in the first period of the pandemic. It was very clear, as I was a member of the Moderna vaccination procedure. There was a lot of people who was hesitating, especially people who have a religious background, if it is kosher or it's halal. So they were not really sure if it's really something they can take to protect them from the COVID. So this is two very, I believe, important notes we have to add here if we want to cover more details about this. That's it. Thank you.
No, thanks a lot, and indeed very good points. Christel, I don't know if you would have any insights on this.
Yes, indeed. I think it's a very important comment, and I had it actually also in my conclusions, which I skipped. But yeah, it is indeed the case that this was based on the official numbers of vaccinated individuals. And I think especially individuals with a background, for example, in Turkey, Eastern Europe, but also the Netherlands, it could have been that they were vaccinated there. And of course, they were not in the official statistics. So that's a very important comment. And we see that also, for example, people living typically in the border regions of Flanders, for example, and working in the Netherlands. Also in this big initial phase, they were able to get a vaccine in the Netherlands where they were working. So that's a very important comment indeed.
Okay, thanks.
Thank you.
Yeah, thank you. So with that, I would suggest that we could move on to Wouter for the concluding remarks on the webinar. So let me first introduce you, Wouter, and thanks again, Sophie and Céline. So Wouter is a medical doctor with expertise in public health and social determinants of health. In 2007, he became the medical director of the Belgian Lung and Tuberculosis Association, BELTA. And BELTA implements tuberculosis control strategies in Belgium and improves respiratory health through a network of low-threshold health centers, community work, and outreach strategies. And during the COVID crisis, Wouter provided policy advice with regards to COVID-19 contact tracing, building on the experiences that he had developed in the past decades on tuberculosis, also on vaccine motivation and how to reach the underserved population groups. So we believe that he's in a very good position to conclude this webinar and to share his thoughts and insights with us. Thank you, Wouter.
Thank you, Brecht, for this nice introduction. And I wanted to start that to conclude that actually we as a country in Belgium, we did a really very good job in vaccinating our people. Even in the lower coverage groups, we did quite a good job in the end. Some groups needed a little bit more time to catch up, but in the end, not bad at all. Even in the Magra group, like Mohammed said, in the end, coverages were quite good, impressive. And indeed, we were hired or contracted or organization by the Brussels government to try out a pilot project outreaching towards the African community in Brussels at Matonge, in the Matonge area. So we set up space at the famous shopping center in Matonge. If you know Brussels, you know this shopping center. We hired or contracted local people or peers from within the community, very personal, very close by, in different languages, in Lingala. And there we found indeed a low coverage, but not a low willingness. So that's a warning I want to make. Don't switch, don't mix up willingness with coverage. Because we, on a small scale, managed to improve the coverage quite easily by just working, following the state of art, reaching out to the underserved. And then we come to the question of Brecht. So how should we do this in the future? And that is called equity by design. From the first moment designing interventions, you need to take into the account the socioeconomic and other demographic inequalities and build them into the intervention, into the policies. What I heard as well is I think there might be a need to, in some way, register a better registration of what we could call ethnicity and race. This was advised in somewhere February 2020 to do that. It was not taken up, but was certainly advised several times. And now, because now we do not have good enough data, I was very impressed with all the work shown today and all the presentations, and it's great science and great scientific work. But better data on ethnicity and race is necessary because now sometimes we switch from non-Belgium to ethnicity, and a French person is not considered different ethnicity than a Belgian. So you can come up with wrong conclusions if you switch definitions there. Looking at what has been done in other countries is always necessary, and a good example is the UK. and the work of, for example, Rohini Mathur of the London School. She has a database of 17 million people, and they do register something like ethnicity and race in their BAME, it's called BAME or BAME. So the UK registers ethnicity, and it's very clear. If you have a big database like that, you can control for other interfering cofactors, and it's very clear that it is not the socioeconomic situation that is the biggest factor in race ethnicity being a determinant of health. So it is not on socioeconomics, it's both, and they're both very strong factors. I'm almost there. Compare the comparable, yes. If we are politically motivated to think, to compare Brussels with Flanders, and actually that's not a fair comparison. You need to compare Brussels with another city, with a comparable city, with as high a percentage of poverty. So compare Brussels with some postcodes in Antwerp, and you get quite a different conclusion. And about trust, it's about trust. I like the last two presenters very much. They put indicate an attention to the trust which is necessary. And for the future, actually in the design of the contact tracing in February, March 2020, I clearly stated that these contact tracers should be embedded within the community, should be local, there should be a almost personal tie with the population, and they should work in a peer-to-peer basis, more or less, and using the trust. So your local contact tracers would be your coach during the whole epidemic, so also your vaccine motivator. That was the idea, to set up this trusted people within the communities. This changed into an anonymous call center, and yeah, that was not the idea. So that's a lesson for the future, building on that local, within or outside the existing structures. So option 2 or 3 in the last presentation. That I think that's a very positive lesson of the future, because something like ethnicity and race, it's not an unmodifiable factor, it's a modifiable factor. And here I want to refer to this very recent huge publications, or a whole issue of the Lancet on racism, structural discrimination and health, where it's clearly explained that you can, by modifying the behavior of your government, but also of your public health service and your community, that the factor of ethnicity and race can be lowered, or the impact can be increased, or the impact on health can be increased very clearly. I think I'm out of time, but I really want to congratulate all of the presenters with their excellent work. Well done. This is the way to go. More data, better data, and next time we are ready to set up a better system.
Okay, perfect. Thanks a lot, Wouter, for these very inspiring concluding remarks. And indeed, I remember equity by design, better data, and public health interventions based on trust, that this is the way forward. So with that, I'm very happy to conclude this webinar. I want to thank you all for being here. As mentioned, the recording and the slides will be available via our website. And we are very much looking forward to seeing you at our future webinar, which will take place in 3-4 months from now. The topic is still to be decided, but you will be the first to learn about this new topic. So thank you all very much. Thanks especially to our speakers, and I wish you all a very nice afternoon and look forward to seeing you later. Thank you.